Okay, so Mr. H is a 24-year-old gentleman presented with double vision since end of January 2022 for 4 months duration. It is a gradual in onset and progressively worsening in the past 1 month, and the double vision was constant. So it worsens upon up gaze and extreme left gaze, which caused him to have gait instability while going up and down the stairs. There's no double vision when looking at other directions or when changing the head posture. He claimed that it improves when he covers either eye, and patient does not notice any obvious eye deviation when looking at the mirror. So he went to seek treatment from the ophthalmologist in private hospital and subsequently was referred to HUKM Optal and Neurosurgery team. So he denies any blurring of vision, no restriction in visual field, no orbital pain, no recent history of trauma to the eyes, no redness of the eyes or tearing. Patient also denies any drooping of eyelids, neither does the eyelid become completely closed at the end of the day. There is no proximal muscle weakness or fatigability, no dysphagia or dysarthria. He denies any headache, nausea or vomiting, and there is no photophobia. There was also no body weakness or numbness, no facial numbness, and no giddiness or vertigo. So for past medical history, it was insignificant. For past surgical history, also insignificant. He does not have any surgery before this. There's no drug or food allergy. For family history, his paternal grandmother has breast cancer and elder brother has thyroid disorder. Social history, student is an IPTA. He obtained degree in mechatronics engineering, single and staying with family. So for general physical examination, his GCS is I4, verbal 5, and M6, which is 15/15. On general inspection, he's alert, comfortable, and well-built. There's no ptosis observed, no disconjugate at primary gaze, which is squint. There's no proptosis or conjunctival redness. Systemic examination, cardiovascular system, you can hear S1, S2 heart sounds, no murmur. Respiratory system is unremarkable, and abdominal examination is also unremarkable. For full neurological examinations, the cranial nerve examinations will assess all 12 cranial nerves. The smell sensation is intact. There's normal visual acuity, visual field, and accommodation. Third nerve is intact. Fourth cranial nerve, limited elevation on both eyes. Sixth cranial nerve, limited abduction on both eyes. Corneal reflex is intact for fifth nerve. No weakness over the muscle of mastication. Jaw intact. No facial weakness or asymmetry. Normal hearing test for 8 cranial nerve. Prenese and Weber's test is negative. 9 and 10 cranial nerve, gap reflex is intact. 11 cranial nerve, no shoulder drooping. 12 cranial nerve, no tongue deviation, atrophy or fasciculation. For motor system examination, tone is normal, power is 5/5 upper and lower limb, reflexes normal reflexia, Babinski equivocal bilaterally. Sensation is all intact, while cerebellar system, no titubation or staccato speech, no dysdiadochokinesia, normal pass pointing test, no pendular knee jerk and tandem walking is negative. So then the case is referred and examined to the optal team by Dr. Osmaliza, and he will explain further regarding eye examination.
Thank you. Assalamualaikum. Thank you, Dr. Nabila. This patient was referred to us on the 3rd of March by a private ophthalmologist, and upon with the symptoms of vertical gaze palsy to rule out causes. So, yeah, can I have the next slide, please? Yeah, upon examination, we did routine visual acuity refraction. It is within normal range. There is no RAPD. The intraocular pressure is normal. Next, please. So basically, this is the general appearance of this patient. Okay, this is a video taken. Okay, actually, cranial nerve 6 is intact in both eyes. Yeah, you can see that there's a full abduction in bilateral. Okay, now patient looking downward. Dextrodepression. I'm looking upward. Having difficulty of looking upward. Okay. So you can see that there's a bit of nystagmus there, and presence of scleral shows superiorly shows an inadequate elevation. Okay, now we are asking physician to do accommodation. Okay, next please. So what you can see is that convergence are intact, but noted there's some retraction nystagmus present bilaterally during examination. There is linear dissociation. However, we can't really portray or demonstrate it in the video just now. There is no anisocoria. Next, please. So obtained function test, basically normal, including the confrontation. Okay, next. This is the Hess chart looking into the muscles. Okay, next one, please. Okay, I would like to share my my slide. Can you stop sharing yours, please? Okay. As a whole, this slide I'm talking about the summary of the case and the approach as well as updating the progression of this patient. Okay. So as for summary, so we have seen before, this is a 24-year-old male with no medical illness. He basically presented with binocular vertical conjugate diplopia with presence of nystagmus and retraction and linear dissociation. So this is the photos in 9 gaze. So at primary gaze, you can see there's not much of changes there. But as you can see, as he looks upward, there's slight scleral show seen, indicating that it is there is some restriction, there is some palsy there. Okay. So before we proceed on to the looking into what's going on, we need to, there is approach of onto how do we deal with this kind of scenario. So I mainly put up this slide as to as for the medical student as well as my master student. So first of all, with a patient having a diplopia, complete diplopia, so we need to ascertain whether this is a monocular diplopia or binocular diplopia, and we will ask this question: does the diplopia disappear upon covering either eye? If it's yes, then it's binocular. If it's no, so if it's the affected eye, if we cover the unaffected eye and the presence of diplopia, most likely it's a monocular diplopia. So what are the causes of monocular diplopia? So the usual ones like astigmatism, uncorrected one, cornea, dry eyes, having corneal scar, pterygium, keratoconus, having had iridotomy for laser procedures due to glaucoma and any glaucoma procedures that basically creating a hole in the iris, and then iridodylisis secondary to trauma. So lens, any cataract or subluxated lens, any retinal maculopathy, others will be cortical diplopia and psychogenic. So what happened in this scenario, in particularly the refractive cornea, iris lens, and retinal maculopathy, there will be scattering effect, and this actually leads to glare as well as a double image. So so these are the reason that you have a monocular diplopia. So once in this patient, patient has we have confirmed that it's a binocular diplopia. Things that were, especially for my master student, thing that would strike us is actually to perform to ensure that this is strabismus in relation related to strabismus. So we need to do a cover and cover test, and to break down the fusion and ensure that the movement are full, the eye movement are full. So which is not there in this patient. So the next thing in mind is when you have a binocular vision, binuclear diplopia. So you need to ascertain whether this is extraocular muscle related, or this is a neuromuscular junction related, or any cranial nerves involvement, or whether this is related to supranuclear deletion at the supranuclear level. So when it comes to extraocular muscle, so these are the several causes that we would like to look for and we would like to ascertain. Causes will be like example, restrictive syndrome. Patient has a patient being diagnosed of thyroid eye disease or trauma related. For example, had recent trauma and then the muscle of the extraocular muscle entrapped within the area of fracture, so and cause restriction. Others would be like idiopathic orbital inflammatory disease. So this is the above photo is the photo of our patient here, and down below is a patient with thyroid eye disease. So I just want to show you the fact that there is no features at all of thyroid eye disease in our patient. So in thyroid eye disease, we expect, like, for example, temporal flare. You know, you can see there's upper and lower lid retraction, fullness of the upper and lower lid, and patient will come with proptosis. So there's another features of thyroid disease apart from having double vision. So these are things that the features are not present in our patient. So next, we look into the neuromuscular junction. So differential diagnosis will be like Myosinography. So in this patient, there is no ptosis, and patient has no negative of this sign, Cogan lid twitch and fatiguability test. So how about cranial nerves? So we examine this patient accordingly, and there is none of those. So I just want to show you guys a quick examination. How do we look for a third cranial nerve palsy, right? So first of all, there will be complete ptosis as demonstrated in this video. And then once we lift up the eye, we can see, and we can see there is no movement at all for the affected eye, except looking abduction. Okay, when ask patient to look down, outward, looking medially, there's none at all, right? And this patient will also need to assess pupillary involvement, and it's not, and then this pupillary involvement in this patient is spared. Okay. So how about fourth nerve palsy? Okay, so this is the features of fourth nerve palsy, right? So basically, we look for any elevated. Upon looking forward, the affected eye will be slightly elevated or hypertrophia, and then we ask patient to look at adduction, and then the elevation become worse, right? And decreases as they look abduction. And then we tilt the head to the affected eye, so the elevation will be increased. And then to the contralateral eye, it will be decreased. So we do a Vygotsky head tilt test. Yeah. So basically repeating back the similar things that I mentioned earlier on. So how about sixth nerve? Right? You can see we ask patient to look, basically assessing the horizontal muscle, which is sixth nerve, right? Or abductor nerve. We ask patient to look right and left, and you can see that it's affected on this right eye. So patient really can't look to the right, or we ask patient to abduct, yeah, or dextro version. So you can see there is restricted there. So patient has sixth nerve, right sixth nerve palsy. Sorry. Okay. Sorry. Sorry, I just need to, yeah. Okay. In cranial nerve palsy, of third, fourth, fifth, we need to ascertain whether this is nuclei or fascicle, subarachnoid, cavernous sinus, and orbital apex involvement. And this is actually with a combination of several canal palsy. Sometimes, for example, cavernous sinus, you can have sixth nerve palsy with funnus and nerve. Like orbital apex, we can have involvement of second nerve. Okay, so let's look at the supranuclear. Right, causes of the supranuclear will be like internuclear ophthalmoplegia, one-half syndrome, gaze palsy, gaze paralysis, like for example, in our patient, vertical gaze palsy, secondary to Perinaut syndrome, and horizontal. So I just repeat back the video just now. So basically, we ask patient to look right and left, okay? And then, right, we ask patient to abduct, to look up and right, and you can see that there is a patient having difficulty of looking upward at this point. Okay. All right, and then we ask patient to look down, and you see it's full movement. Okay. And this one looking up, you can see that he can't elevate the eyes. And then looking upward, there's full movement. So back to primary gaze, ask patient to look up again, and you can see that there is a scleral show present here at the superior part of it. So it shows there is no full movement. And a bit of nystagmus. Okay, now we ask patient to accommodate. Accommodation is actually intact in this patient, but there's presence of light near dissociation. So this is basically the patient. So then I would like to update this patient. You can see that we have seen the preoperative before. Now this is a post-op about a month after surgery. Okay. Okay, we ask patient to look to the right, to look to the left. You can see that the retraction is actually lesser. Right? This is exactly 1 month after the surgery and gamma knife. And you can see the scleral show there is none at all, not fully, but better compared to the pre-ops. Okay. Otherwise, other extraocular movement are intact, full and present. So we made a comparison between pre-op and patient looking upward. Then you can see that pre-operative, you can see that there's a bit of scleral show, and here post-op, the scleral show is actually diminished. There's improvement there. So it's just about 1 month. So we hope for better results later. Okay, Nabila, can back to your slide, please?
Sure, Prof.
So what is Perinaut syndrome? It's actually, another name for it is actually dorsal midbrain syndrome or Sylvian aqueduct syndrome. There are several names attributed to this syndrome. It's actually, I really like this slide. It's actually to give some mnemonic in terms of clinical features of Perinaut syndrome, clues. Actually, convergent retraction nystagmus, light near dissociation, up gaze paralysis, idly retraction, and skew deviation. Okay, next please. So Perinaut syndrome is actually in regards to the vertical gaze center. So there are a few important structures in our vertical gaze center, namely the three part of it. RIMLF is actually rostral, medial longitudinal fasciculus. It's actually a burst neuron that fires an upward on the upward and downward gaze. and also stimulate cranial oculomotor nucleus, and as well having a unilateral lesion will produce defect in downward gaze, whereas bilateral lesion causing abolish all vertical gaze. So we have also internucleus cajal. It's actually a neural integrator that will projection into third, fourth, and contralateral into the internucleus cajal via the posterior commissure. So the posterior commissure is another third structures that connecting these nuclei basically. So bilateral lesion is actually causes limited range of vertical gaze and gaze holding as well as circuits. So another thing is actually a third structure, important one is actually the posterior commissure, which is actually situated the superior part of the third ventricles at the dorsal aspect of it. So connecting these nuclei. So defect at this area actually diminish the effective the upgaze part of our eyes. So that's about basically a summary of vertical gaze center. So next slide, please. So in our patient, so he do have a retraction nystagmus, okay, right? Not much of conversion, right? And you do have an upgaze. It does have the upgaze paralysis. Eyelid retraction, you can see there's eyelid retraction there. And light near dissociation.
Like this. Okay, bagus.
There's a bit of conversion there. So not much of conversion, but it have a retraction and nystagmus. Okay. I move on to the next presenter, please. Thank you. That's about my part. Thank you very much.
Sorry, Dr. Ahmadiza, based on the clinical symptoms and signs here, where did you localize the pathology here?
I would say at this point, I would say somewhere in posterior commissure or either RI or an N, RI, MLF.
Okay, so somewhere in the region of the midbrain, yeah?
Yeah, somewhere in the region of the midbrain, postulating about dorsal aspect of it. I think my bet will be posterior commissure.
Okay, thank you.
All right, so as a summary of the presentation and examination findings, the patient is a 24-year-old gentleman who presented with the Diplopia and Perinaut Syndrome. He has impaired outward gaze and however has normal visual acuity and visual fields, and there is no increased ICP symptoms. So the provisional diagnosis that we've reached so far would be pineal lesion, or it can be total plate lesion, or it can be due to congenital hydrocephalus, or vein of Galen malformations or aneurysm, and ocular myasthenia gravis. Next, the patient was referred to a neuromedical specialist, consultant, Prof. Rabani. She'll talk about differential diagnosis in diplopia in neurology, physical examinations, and workup and investigations.
Thank you very much for the invitation. Thank you, Dr. Osmaliza, for a very comprehensive details on differential diagnosis. So it makes my task easier to make the medical student to understand. I think for the benefit of the medical student, it is very important whenever patient presented to you with diplopia, it is very important to differentiate whether, you should have few differential diagnoses in mind. So that will help you to actually ask relevant targeted history. And of course, we will go through some of the investigation and also physical examination. So this can be some of the reputation, all right? So differential diagnosis of diplopia in neurology In neurology, typically we are very much interested in binocular diplopia, as what Dr. Osmaliza has mentioned earlier. Monocular diplopia tend to be related to the globe problem, lens, and retina problems. So in neurology, whenever we have patients with diplopia, we have usually divided into different neuroaxes, whether or not it is the lesions are actually purely in the brain, whether or not it's an isolated cranial nerve problem, which is cranial neuropathy, whether or not this could be a neuromuscular junction disorders or muscle disorders. I think Dr. Osmaliza has gone through few of the differential diagnosis of brain pathology that can give rise to binocular diplopia. So it is very important that you have this differential diagnosis in mind, so that it's very important for you to go through the history. You know, I think if you go back to this patient history, this young gentleman presented with gradual onset diplopia, which is persistent throughout of the day. All right, so there is no history of fluctuation of symptoms, or fatigability, or worsening of diplopia towards the end of the day. So these are a very important clue that you always have to ask when patient presented with diplopia. And importantly, you can develop diplopia in cases of stroke or internuclear ophthalmoplegia in some of the demyelinating disorders, so they tend to be sudden in onset. So that might suggest a vascular origin or vascular causes, right? As what I've listed here, brain pathology could be internuclear ophthalmoplegia, gaze palsy. You can have that sometimes in patient with stroke, for example, MCA stroke. You can have lateral gaze palsy, skew deviation, like what Dr. Osmaliza mentioned. In you have to exclude strabismus. And in cases of dorsal midbrain syndrome, we do see that in neurology in cases of demyelinating disease, for example, neuromyelitis optica spectrum disorders. And of course, not to forget, tumors can also arise from this region. Important rare condition that we see in neurodegenerative disease, which is progressive supranuclear palsy. So this is one of the important differential diagnosis. However, they tend to be in slightly older patient. When we go to the next differential diagnosis, looking into specific nerve or cranial neuropathy that actually supply your rectus muscle, I think Dr. Osmaliza has gone through very clearly how you differentiate third nerve palsy, fourth nerve palsy, or sixth nerve palsy. So remember that if this is just an isolated condition, it can be mononeuritis in neurology. So it can be due to vasculitis. So of course, that will help you in sending relevant investigation. A very important and common condition that we were referred is actually neuromuscular junction disorder, which is myasthenia gravis. So patients tend to come with diplopia. And in myasthenia gravis, I would say almost 80% of patients will have ocular symptoms. So diplopia is one of the commonest symptoms in myasthenia gravis. However, they tend to accompany by partial ptosis in most of the patient, and history of fatigability or worsening diplopia after long driving or towards the end of the day tend to be very significant in patient, which is absent in the patient that we are discussing today. So the next important differential diagnosis is muscle disorders. Thyroid eye disease is not as what Dr. Osmaliza has shown, a very nice picture of the thyroid eye disease. Sometimes it can coexist with myasthenia gravis as well. So because they are all autoimmune conditions. So always look at features whether or not they have concomitant thyroid and myasthenia gravis. Mitochondrial disease or congenital myopathy, they can have ophthalmoparesis, restriction of eye movement, but because these tend to occur early in life, slightly less patients tend to complain of diplopia because they have adapting to the vision already by then. Orbital fracture, orbital mass, orbital apex syndrome, can also cause restriction of the movement, problem in your rectus muscle. So then it can also cause diplopia. Inflammation of the rectus muscle itself due to infection will result in diplopia. We can go to the next slide. So whenever you have a patient with diplopia, how do we approach in neurology? Of course, you will need to do complete neurological examination. When you examine the face, you look for other features that might help you to narrow down your diagnosis. Whether or not they're having myopathic faces, high arch palate, that might suggest these are congenital disorders. You're looking for isolated cranial neuropathy. Is it an isolated cranial neuropathy, whether or not this is a complex ophthalmoparesis or ophthalmoplegia? So that will give you, to narrow down your diagnosis, whether or not this is an isolated condition, whether or not this is due to, a supranuclear problems, or whether or not this is an autoimmune condition. Very importantly, in all patients that you see with diplopia, you need to check for presence of fatigability, because some of the patients might have very subtle ptosis. So you might miss that if you don't really check for fatigability. So fatigability is basically your specific test that you can actually check in the lab, in the ward, or in the clinic. All right, so you can actually proceed with fundoscopy examination to look for retinitis pigmentosa or papillary edema in patients with hydrocephalus. They can develop bilateral sixth nerve with diplopia. Retinitis pigmentosa, you can see that in patients with mitochondrial disease. And of course, you can proceed with complete upper and lower limb neurological examination, specifically to further narrow down your diagnosis of diplopia secondary to neurological condition. I think we know earlier that stroke patient can also have cranial neuropathy. So you're looking for lateralizing signs, upper motor neuron signs, that might suggest you that this cranial nerve or diplopia is actually originating from the brain areas. You should also look for proximal muscle weakness, limb fatigability in case of suspected myasthenia which is absent in this patient. So how do we investigate diplopia? Of course, you would like to do a routine blood investigation. And also in neurology, if patient has got other clinical signs that might suggest generalized condition, for example, in cases of myopathy or myositis, we would send some relevant investigation, especially creatine kinase, serum lactate for mitochondrial disease. Autoimmune screening, of course, that will depends on what is the history would tell you more. For example, thyroid function test, testing for ANA, double-stranded DNA, because some patients have internuclear ophthalmoplegia as the first presentation of neuropsychiatric SLE. And not to forget, importantly, as I mentioned to you, diplopia is one of the commonest presentation of ocular myasthenia gravis. We can send acetylcholine receptor antibody for the patient. Just to recap, this patient was actually seen by the private neurologist, and the antibodies were sent and came back as positive with very low titer. So taking into account, we proceed with neurophysiology test just to exclude the possibility of myasthenia gravis. But of course, we are aware that at the beginning, the clinical history, clinical examination, as well as our neurophysiological test actually does not fit the diagnosis for myasthenia gravis. So hence, we arrange for the imaging of the brain. And importantly, if additional orbit might be required in certain condition. So I think the next panel will discuss interesting MRI imaging later on. And of course, we will also refer for ophthalmology assessment for detail to exclude that this diplopia is not due to eye globe problems and things like that. So I think I hope that everybody is clear in this presentation that we can actually quite confidently exclude ocular myasthenia or myasthenia gravis by just clinical history, physical examination in the patient that we're discussing today. Thank you very much.
Thank you, Prof. Rabani. So next, few imagings was ordered for this patient, which is CT brain and MRI brain contrast. So Prof. Shahizan will explain further regarding the imaging features, showing hydrocephalus, pineal, and tactile plate region.
Okay, thank you very much for the invitation. So I'm going to talk about the imaging for this patient. So in summary, this quite a young man, age 24, who presented with Diplopia and Perinaut Syndrome. So a few differential diagnoses was given, wanting to look for any abnormality in this area. Next slide, please. Since I'm going to just show you the schematic diagram of the pineal region, the schematic diagram and the MRI representative. The important structures that you can see here, at the center, you would see the posterior commissure, which is labeled PC on the schematic diagram, followed by pineal gland, PG, and TP, which is the tactile plate. Alongside with it, you can see a couple of structures. The blue structures are the veins, the red structures are the arteries, and we can also see the splenium of the corpus callosum. The midbrain is located anterior to the tactile plate. Okay, next please. So in this patient, MRI was done, and I hope you can see that there is a lesion. I'm pointing at an arrow, but I'm not sure whether you can see it or not. There's a lesion at the region posterior to the third ventricle on T2 weighted image, which is the first image. You can see that it's a lobulated lesion, and it has got some microcystic component within it. The next image is the T1 post-contrast, and you can see that there is a very subtle enhancement at the lesion that we see. The sagittal view clearly demonstrates that there is a lesion which is centered at the region of the posterior commissure as well as the pineal gland, and it also involves the tactile plate. And we can see that there is an obstruction to the aqueduct or sylvius, and this results in hydrocephalus. Can you move to the next one? This is the CT of this patient, and we can see that the lesion itself is dense on plain CT, and you can see that there is pineal gland calcification, and the pineal gland calcification is being displaced posteriorly rather than engulfed by the mass. Next, please. I'm just going to show you what hydrocephalus looks like because I think this is one of the complications that can arise from a lesion that can occur in the pineal gland region, especially when there is obstruction to the aqueduct of sylvius. If you look at the the occipital horn of the lateral ventricles, it's all balloon out. The third ventricle, which is the structure anterior to the lesion, you can see that it's ballooning out and it has a convex border. And the third last image is the body of the lateral ventricle, and you can see that there is disproportionate dilatation of the ventricle when you compare it to the adjacent sulci. And in this image as well, we can see that there is periventricular hyperintensity. This is unusual and uncommon in patients of this age, and usually in cases where it is associated with ventriculomegaly, enlargement of the ventricle. It means that the ventricular system is under pressure, and there is a seepage of contrast into the parenchyma. Next slide, please. Okay, this is the sagittal view, which clearly demonstrates hydrocephalus. You can see a couple of signs here, one of which would be bowing of the corpus callosum. The corpus callosum is still out. That's bowing of the corpus callosum. And if we can go to the floor of the third ventricle, which is, yeah, that's somewhere there, anterior, yes, you can see that it is actually being depressed downwards. So these are all the signs of hydrocephalus, and the third ventricle is under pressure. I'm showing you the post-third ventriculostomy, which was done for this patient. We can see now that the system is less under pressure, whereby we can see that the floor of the third ventricle is now elevated, and it assumes its normal position. Yeah, that one. And anteriorly, you can see that there is a flow void. Can you just click for the next slide? Right, so these are the areas that I'm going to show you. Another one. Okay, yeah. So this flow void indicates that there is fast flow of CSF between the third ventricle and the prepontine cistern, meaning that the third ventriculostomy is patent. Next, please. So in summary, we have a dense pineal region lesion, which causes displacement of the pineal calcification. The morphology of the lesion itself, it has got T2 heterogeneous appearance with a microcyst, and there is a bit of enhancement following contrast media. So, and the MRI also shows that there is complication that arises from this lesion, which is a non-communicating hydrocephalus. Next, please. So we have a couple of differential diagnoses. When we have a lesion around the pineal gland region, the commonest in this age group would be a geminoma. It appears dense on CT, enhancement, but it typically would engulf calcification. The other differential diagnosis would be pineoblastoma. Again, it will be dense on CT, enhancement, but it displaces calcification. Usually it will be of a large tumor, and usually the age group would be more of in older generation. Another differential would be a glioma. Usually it will be tactile in origin, but there is no enhancement typically. So in this patient, the differentiation between geminoma and pineoblastoma would be difficult at times, especially if it doesn't fit to one pattern. But if looking at the commonest tumor that would occur, it would be a geminoma. So since this lesion is still small, it's a bit difficult to really narrow down to one. So we need to correlate these findings with a biochemical analysis, looking for specifically for alpha fetoprotein and beta HCG to rule out geminoma. That's all from me. Thank you.
Right. So following the imagings, we sent off few blood investigations. The routine bloods that we sent is FBC, coagulation profile, RP, and LFT. So all these 4 panels showing normal results. We also sent hormonal profile to see whether there's any thyroid abnormalities, but the TSH and T4 level is also normal. Because of our provisional and differential diagnosis, thinking of pineal region tumor, we sent off beta HCG and also alpha fetoprotein. However, both results are not raised, and it's within the normal range. All right, so as a recap of the summary, this patient is a 24-year-old gentleman who presented with Diplopia and Perinaut Syndrome with impaired upward gaze and has normal visual acuity and visual field. So MRI features showed acute hydrocephalus changes with pineal region tumor with normal tumor markers. So next we'll proceed with management strategies, which will be explained by Prof. Ramesh.
Prof. Ramesh, I think you're muted.
Okay, sorry, thank you. So at this stage, we have a 24-year-old man with pineal region tumor and hydrocephalus. So various different options were discussed with the patient, including conservative treatment. However, the patient already has got hydrocephalus and a tumor. Subsequently, we went on to discuss about VP shunt. The problem with VP shunt is that you don't get a tissue diagnosis and there's possibility of dissemination of the tumor cells. The third option was endoscopic third ventriculostomy and biopsy. So endoscopic third ventriculostomy is the use of an endoscope to make a hole, which is your ventriculostomy in the third ventricle, as shown by Prof. Shaizun earlier on, and to perform biopsy at this stage as well. The fourth option will be a stereotactic biopsy. However, this probably is more suitable when there is no hydrocephalus, because you can only get a biopsy and you wouldn't treat the hydrocephalus at this stage. The fifth option was open biopsy. However, this region, as you can see in the earlier diagrams, there are a lot of important veins and blood vessels in this area as well, and does carry a certain amount of risk. So finally, after discussion with the patient, we opted for endoscopic third ventriculostomy and biopsy. Okay, so the patient was placed under general anesthesia. You can see the head is fixed in a head clamp. We call that a Mayfield head clamp to secure the patient's head. We don't want the patient's head moving during surgery. And then the next picture, you can see the image guidance system that we use. So the image guidance system, as a summary, is like our Waze that you use. So it literally guides us into the brain where we want to go. It gets us to see us where we want to be as well. Okay, next slide. So this was our pre-op planning. So the picture in the center is our image guidance pictures that helps us to where we want to go. On the top left-hand corner, you can see the curvilinear incision, which is our skin flap. And then you see the midline there, which is where the sagittal sinus is. And then you see a line coming off across, which is your coronal suture. And then you see the two axes marked there, which is our pre-op planning where we are going to do our burr holes. So the picture below, you see the skin flap elevated with the two burr holes. The upper one is the frontal one, and then the back one is the posterior one, which is over the coronal suture. So the reason we did two burr holes in this case, as you can see on the bottom right-hand corner, one is to do the top burr hole is to do the endoscopic third ventriculostomy, and the second burr hole is to take a biopsy. The reason we have to do two burr holes because the angle is very acute. If you try to do it from the first one, there is a high incidence of injury to the fornix, and the patient can have memory problems. Okay. So this is picture on the top right-hand corner is stoma being performed in the floor of the third ventricle. And the next picture is a balloon using to widen the stoma. Can we go to the next slide? So this is what a very nice anatomy picture of what the brain looks like from the inside, an endoscopic view. So on the right-hand side, you have the label diagram, but I'll take you through it. Right on either side, you can see the optic chiasm. In the center there, that reddish structure is your infundibular recess. Below that is your pituitary stalk and pituitary gland. Behind that, you see a very thin membrane. That's the floor of the third ventricle that's been thinned out. As Prof. Shaizun showed you earlier on from the sagittal MRI, how it was being pushed down. And just below that, you see that reddish structure, the tubular structure, that's your basilar artery. And on either side, posterior to that is your mammillary bodies. Okay. So this is the first video. You can see the catheter being introduced. We're going to make a hole in the floor of the third ventricle. And you can see that it's just anterior to the mammillary bodies and the basilar artery. The next video, you can see us widening this hole with a Fogarty's catheter. So we test the balloon first before we go in. So we now dilate up the balloon. And the balloon is gradually withdrawn back to widen the stoma. Okay, so that's what you want to see, a widened stoma where the flaps are quite patent at the end. Sorry, Belle, can you just go back to the last video to show them the structures in the basilar? So that's the patent third ventriculostomy. So now we put the camera into the below the floor. There you see is the basilar artery. You see the perforators on either side, and then the web-like structure that you see anterior to that is the arachnoid. So the blood vessels in the brain run in the subarachnoid space. So the next video, yeah. So finishing the third ventriculostomy, we now have to go back via the second burr hole to take a biopsy. So this is in the posterior third ventricle. You can see the fungating mass in there. Yeah, so that's the tumor in the 6 o'clock position. And just above that, the narrowed structure that you see posteriorly is the narrowed aqueduct. So at this stage, via the endoscope, we will pass down a biopsy forceps to take a sample. Okay, we can proceed to the next slide. So this is an enlarged view. So you see this fungating mass in the back of the third ventricle, and then the narrow aqueduct there.
So post-operatively, patient has no increased ICP symptoms and the diplopia remains the same and not worsening. Subsequently, an MRI whole spine was ordered to look for any drop metastasis, which was negative. We also sent CSF cytology during the surgery. However, the result was unsatisfactory for evaluation and mainly there's peripheral blood component. So here's the post-op imaging of the CT of the MRI. You see the resolution of the hydrocephalus and also MRI whole spine. So next we'll discuss regarding the histopathology slides by Dr. Farhan.
Hi, good morning, everyone. Is it okay if I share my own screen because it's easier for me to point out what are the things that I want to show? Okay, assalamualaikum and good morning, everyone. So I'll be presenting the histopathology finding for this case. So we received multiple fragments of tissues. So this is under low power. And under slightly higher power, we can see the presence. Hold on, let me just change my pointer. Okay, you can see the presence of malignant tumor, which is over here. They're arranged in sheath pattern. And then they are being surrounded by fibrotic stroma. There's also presence of the inflammatory components, which are the lymphocytic infiltrate. On the low power, you can see there's a bluish area over here. Same goes to over here. They're also present in between the tumors over here as well. And under high power, this is time 40, we can see that the tumors are large. And displaying round to irregular. Some are rounded like this. However, some may look a bit irregular, like over here and here, and in over here, and the tumor cell have vacuolated cytoplasm, and in between these tumor cells, there are presence of lymphocytes, like over here, here as well, here and here. Mitosis is easily seen under this times 40 field. We can see the presence of 4 mitosis, one over here, 2, 3, and 4 mitosis. They are obvious. And we'll proceed with the immunohistochemistry. We're using the PLAP, or placental-like alkaline phosphatase. This is a marker for a germ cell tumor, and it will stain the cytoplasm as well as the membrane. So in this case, it is positive, staining the tumor, cytoplasm, and membrane. However, the PLAP is not specific. So to further confirm, we're doing the CD117, or the other name is c-KIT. It will stain the cytoplasm, the membrane, as well as the Golgi region. So in this case, again, this tumor is positive. So this is the Golgi region that is pointed here. And then the membrane is highlighted as well, together with the cytoplasm. Because as mentioned before, that the cytoplasm is vacuolated, so we do a pass stain. This is with diastase, and it will highlight the glycogen content inside the glycogen inside the vacuolated cytoplasm. And other than that, it is also PEN-CK can be occasionally positive. However, in this case, it is negative. So I did not include the picture. So all in all, with the H&E finding together with your immunohistochemistry, the lesion is in keeping with germinoma. That's all from me.
Thank you, Dr. Farhan. So since the HPE results turns out to be germinoma, this case was referred to our oncologist, Prof. Fuad, and he will discuss regarding the further treatment. Prof. Fuad?
Hi, good morning. Thanks for sharing this skill with us. So I'm just going to give a brief overview of our thoughts on pineal tumors. And I think Rameh has got further discussions, so I'll try not to potong trip sikit lah. So these tumors are rare, but they do constitute a sizable portion of pediatric brain tumors. So for us, we generally lump them to the germ cell tumors or the parenchymal tumors. So here we are dealing with germinomas and non-germinomas. That would be our main interest. And we could see rarely other type of tumors such as astrocytomas or metastases. Next, please. So germinomas depends on which series you read, but generally it's about 50% of all pineal tumors, and you diagnose them by imaging and CSF with or without biopsy. Sometimes some patient is not possible to do biopsy, and you have a series which has maybe about a few hundred cases, only half of them have had a biopsy because patient may be too ill and they were treated expectantly and so on. So the tumors, the germinomas may secrete some protein, mainly alpha beta-protein beta CD, lactate dehydrogenase and PLAP. Yeah. Now these tumors are infiltrative, and because of their proximity to the CSF spaces, so they can have a propensity to spread through the CSF, and therefore they need evaluation of the spine with both CSF and MRI. So a positive cytology or positive MRI would indicate dissemination, and therefore your treatment strategy will be different. So these tumors are usually treated with some sort of surgery, debulking, and maybe more often just a biopsy. And for pineal germinoma, then they need radiotherapy or chemotherapy or both. And these tumors, both germinomas and non-germinomas, are both chemo and radiosensitive in general. Next, please. So overall, usually we use radiotherapy, and this has been the mainstay of pineal germinomas. Part of this is because there was a concern about the penetration of chemotherapy through the blood-brain barrier. So if you look through the history when before the advent of more accurate CT scan and safer ways of biopsy. So often when patients have got a large tumor in the pineal gland with calcification and looks typically like geminoma, then sometimes you are forced to treat them with radiotherapy. And in a couple of weeks, if the tumor is seen to be shrinking or the patient is improving, then a presumptive diagnosis of geminoma was made and you complete your course of radiotherapy, right? So, and then traditionally, because of the risk of CSF spread, you treat both the head, namely the whole brain, plus the spines. So we treat the whole CSF spaces. So you treat the whole cranium and spine up to about S2 level, and this is called craniospinal irradiation. And given the tolerance of the central nervous system to radiotherapy, so you cannot give such a high dose to the whole CSF. So you give a dose to tolerance, and then you give what's called a boost or additional radiotherapy to the primary tumor. Okay. So this is very traditional, and more recently that they say that you don't really need to treat the whole brain if the spread is through the CSF. So maybe you can just treat the whole ventricular system. And recent study has shown that this is just as effective as giving whole brain radiotherapy. And again, for localized tumors without evidence of CSF spread, there is a move away from giving craniospinal radiation and more focus towards giving ventricular radiotherapy followed by a boost to the primary side. So this will go on to Ramesh's presentation a bit later on. Next, please. Okay, so because we see a lot of children with pineal tumor, and we try to avoid radiotherapy, and there have been trials using just chemotherapy only. Unfortunately, although the responses have been good, the longer-term outcomes have not been as good as treatment with radiotherapy, chemo plus radiotherapy. So the regime that we use is similar to what we use for other germ cell tumors, especially testicular tumors, and this is either BEP, bleomycin, etoposide, and platinum either cisplatin or carboplatin. This is the mainstay of chemotherapy with addition of other agents depending on where you work. So chemotherapy by itself is not enough. You need your radiotherapy focally, but better if you go back to the same results as before, giving whole ventricular radiotherapy. Next, please. So the main concern of radiotherapy is the longer-term side effects. The short-term side effects are very manageable, which include myelosuppression, some nausea, lethargy, somnolence, and so on. But there is longer-term issues of endocrine and hypothalamic disorders. There is most concern is cognitive impairment. The younger the patient, the more likely that there is cognitive impairment, some IQ drop, and learning disability. If you irradiate the spine, then the growth plates tend to stop growing, or they don't grow as much as they should, and patients need to be shorter. And that's alopecia with radiotherapy to the head, and the risk of second malignancies. Remember that these tumors are usually highly curable, so that patients survive and they may survive long enough to get second malignancies. Next. So this is just to show you what craniospinal radiation is about. The bottom picture B is what we traditionally use. So the lines indicate where the radiotherapy fields are coming from. So there are several issues, including because we are using 3 different fields for the one field for the head and 2 fields for the spine. There is danger that where the radiotherapy overlaps, there is danger of overdosing the spinal cord. So we have techniques to overcome that, and getting long-term spinal injury is extremely rare. The top picture A, it shows a modern technique using what we call VMAT or IMRT, intensity modulated radiotherapy or tomotherapy, in order to produce a more homogeneous dose to the craniospinal axis that is indicated in red, right, compared to the bottom. So the dose is more homogeneous and there is less risk of overlap of radiotherapy fields. Next, please. And this is an example of whole brain radiotherapy on the left, where the dose to the whole brain is very uniform. So you hit everything, but you are hitting too much stuff. You don't need to hit certain areas of the brain. And to the right is the ventricular radiotherapy, where you can see that the highlighted red areas is the dose getting high dose area. Yellow is already less dose and blue is relatively low doses. So we spare quite a lot of the brain area, but you must be very meticulous and ensure all the areas of the ventricles are included, including the prepontine system and so on. So now there is a move towards less radiotherapy, ventricular radiotherapy, and also to give even less radiotherapy by focusing just on the primary tumor, because the risk of spread throughout the craniospinal axis is relatively small. So you need to treat a lot of people with extra doses just to save a few patients. And some of these patients can be saved later and salvaged with radiotherapy. So that's all I have for now, because Ramesh will expand on this topic. Oh, sorry, there's one more, and this shows the long-term outcome. Showing that the survival is very good. The blue line is germinoma. And next, please. Remember, there's an extra one. And this is a historical series in 1994 from Stanford. So Stanford is a very big and very famous center. And we can see that the graph of the current survival is so much better than what it was before. And again, I think this is a combination of chemotherapy, getting better diagnosis, and so on. Right. So that's it. I'll pass over to Ramesh.
So patient is opting for gamma knife discussion for gamma knife, so which will be explained by Prof. Ramesh.
Thank you very much. So thank you very much, Prof. Dr. Fuad. As you can see here, from whole brain radiotherapy, we moved on then to ventricular radiotherapy. But despite all this, we still subject a certain amount of normal brain to the effects of radiation. And one of the downsides of whole brain radiotherapy is the more and more we finding patients are suffering from neurocognitive problems. So what is gamma knife stereotactic radiosurgery? So it's basically a single high dose radiation to a small or critical area of the brain. It only focuses on the region we want to treat. And on the right-hand side, you can see the machine that we use. It looks a bit like an MRI machine. It's got a block at one end, which houses the radiation. And then it's got a bed, which is automated where the patient lies. And then it's got an arm on the right-hand side, which is actually a CT scanner. Next slide, please. Press again. So basically, with the gamma knife, there are 192 cobalt sources arranged in a ring, and it's focused onto one point. Each individual gamma ray, when it crosses the brain, hits the brain cells, does not injure the brain cells. But when it's focused to one point, the effects become magnified. So it's a bit like using a magnifying glass, focusing all the radiation on one point. Next, please. So this is what the top middle picture is our gamma knife center in HUKM. So that's our gamma knife machine. On the right-hand side, you can see the inside of the big block there. So all the little circles that you see are your cobalt sources. And it's arranged in 8 sectors. In the picture there, you can see 3 sectors that has been shown. In each sector, you have 24 cobalts. So within each circle there, you have what's called collimators, which is shown in the bottom middle picture. And you can see these long channels running downwards in the middle picture. So these are 4, 8, and 16 millimeter collimators. So depending on the size of the tumor and the critical structures, so smaller tumor, we use smaller collimators. And if it's a very critical area, we like to use smaller collimators to easily shape the beam. And within each collimator, we can do what's called beam blocking. We can further modulate the shape of the beam to try and be as conformal as possible. When I say conformal, that means you want all the radiation to focus within the tumor. So next slide, please. So how we do gamma knife radiosurgery, in the morning of the procedure, the patient has a head frame applied under local anesthetic. And you can see on the head frame, both on the left-hand side, you can see graduations at the base of the frame. So these graduations are important because it actually gives us X, Y, and Z coordinates. So it is based on a Cartesian coordinate system that allows us to localize any lesion within the brain. So after the application of the frame, the patient has MRI scan done. And the MRI is then transferred to our gamma plan, where we sit down and draw around the tumor. So the yellow line you see here is the outline of the tumor. And then once we outline the tumor, we place all the different gamma knife shots we want to put. And then the green lines are the different radiation dose. So typical for a germinoma like this, we would give 15 gray to the 50% isodose. So the 50% isodose is the yellow line you see. So the center of the tumor is very hot. It receives 28 gray. But one of the nice things about gamma knife, you can see the fallout is very low because the last line there is your 4 gray line, which is very safe to the brain cells. So one big advantage is we get to spare the normal brain. We can treat multiple lesions, as germinomas can also have metachronous lesions, and it can be all done usually within a day. And you can see the dose to the brainstem is very low here, 3.3 grays. Tolerance is about 12 grays, so only about 2% only that hits the brainstem. Next. So this is a post-treatment assessment. So you can see his vision is not got any worse following gamma knife treatment. Okay, next. Next slide first. So this is a pre-gamma knife treatment. So on the left-hand side, you can see a mass involving the tactile blade. And then on the right-hand side, in the same region, you can see the mass has a resolution of this pineal region tumor 1 month following gamma knife treatment. So very good response. Up to date, the patient has not have any neurocognitive problems. Can you just go back to the previous slide? So this is the only published large series of use of gamma knife radiosurgery for pineal region tumors. This was a retrospective study. Patients were followed up for over 10 years in 147 cases in China, but only 40 cases on germ cell tumors. So the long-term control rates, if we look for at 3 years and 5 years, you're looking at 88 to 77%. And the survival rates of 60 and 50%. Next. So an overview of pineal region tumors. Pineal region tumors have higher incidence in children compared to adults. So it's, in Japan in particular, it's very common, 3.2%, about 1% in Islamabad, and 1.9% in China. And you can see it's much lower in the US and Europe. For some reason, germ cell tumors are very common in this part of the world. New advancement with MR imaging, germ cell tumors can be diagnosed using MRI and clinical presentation. There is a move to treat these tumors, as mentioned by Dr. Fuad earlier on, without biopsy. So the boundaries of the pineal region, Bella, can you go to the next slide? Yeah, so basically you can see the boundaries as depicted by the 2 red lines. So the upper part is the posterior part of the corpus callosum, and the lower boundary is the tactile plate. The upper part of the posterior fossa. The anterior boundary is the posterior third ventricle, and the posterior boundary is the tactile plate. Okay. So classification of pineal, this slide actually was summarized by Dr. Fuad just now. So pineal region tumors, you have 3 types of tumors. The commonest, as in this case, is your germ cell tumors, which make up about 50% to 75% of tumors in this region. The germ cell tumors, you can have germinomatous tumors, 65%, and then you can have your mixed germ cell tumors as well. The rest make up your non-germinatus germ cell tumors, which is your yolk sac, embryonal carcinomas, choriocarcinomas, and mixed germ cell tumors, and your teratomas. Within the pineal region itself, you can have the benign version, which is your pineocytoma, and your high-grade version, your pineoblastomas, and those that are with intermediate differentiation. Now you have a new type of tumor that's been classified, your papillary tumor of the pineal region, which is thought to arise from the superior medullary velum. And then other common tumors, which are not so common that we need to keep at the back of our minds, is your glial tumors. Glial tumors, not surprising, there's glial cells are the common cells in the brains. Your ependymomas, meningiomas, hemangioblastomas, lymphomas, this new tumor now ATRT, atypical teratoid rhabdoid tumor, which is a very aggressive tumor, and your trilateral retinoblastoma, and mustn't forget metastatic tumors as well. So pineal region tumors, you can have germ cell or come from the pineal gland and other tumors. Next. So this looks like a very busy slide, but actually I will try and simplify it for you. So when we have a pineal region tumor, a patient, most important, must look for, apart from the tumor, whether the patient got hydrocephalus or not. But hydrocephalus is a neurosurgical emergency, has been associated with seizures and sudden deaths. And when we see hydrocephalus in neurosurgery, we worry because we need to do something fairly soon. So when the patient has hydrocephalus present, the next step is to think about a CSF diversion. So our options that we have, we can do a VP shunt, ventricular peritoneal shunt, endoscopic ventriculostomy, lumbar peritoneal shunts. At the same time, we also send off for tumor markers. So you do the endoscopic ventriculostomy to relieve the hydrocephalus, basically. You provide another channel for drainage of CSF. Most important thing with pineal region tumors after that is the tumor markers. Because if the tumor markers are positive, then you don't need a biopsy done. It's either a germ cell tumor or which we often then come to Dr. Fuad and oncology team because they are quite chemo and radiosensitive, as you've already heard above. If there is a tumor marker is negative, then we'll have to consider a biopsy at this stage. So which could be a mature teratoma or a germ cell tumor. So mature teratomas, we need to consider resection. So basically, there are only 3 tumors for neurosurgeon to operate on: teratomas, pineoblastomas, or pineocytomas. The rest are all treated oncologically, chemo or radiotherapy. So if we go to the other side, if hydrocephalus is absent, we send off tumor markers. Tumor markers positive, biopsy not needed. Patient is then sent to the oncologist. If tumor markers are negative, then it warrants a biopsy. Depending on the pathology, as I mentioned, 3 tumors that need neurosurgery: your mature teratomas, your pineoblastomas, or pineocytomas. The rest are all treated oncologically. In terms of follow-up, we repeat scan 1 month after treatment, 3 months, 6 months, and yearly after that. Tumor markers are very helpful when they are positive because they help us to monitor treatment and to pick up also for diagnosis, as mentioned, and also to monitor progression of treatment. Next. So common tumor markers, I think beta-HCG and alpha-fetoprotein. Beta-HCG is produced by the fetus liver. It indicates presence of disease when present in adults, usually a diagnosis of choriocarcinoma or embryonal cell carcinoma. Beta-HCG is produced by the placenta. Alpha-fetoprotein is produced by the yolk sac and later by a fetal liver. So abnormal high levels of alpha-fetoprotein indicates yolk sac tumors. Other cancers include ovarian, stomach, lung, colon, pancreas, and also elevated in liver cirrhosis and hepatitis. Next. Elevated serum markers and CSF alpha-fetoprotein and beta-HCG is considered positive tumor markers. Alpha-fetoprotein more than thousands, very poor prognosis, but beta-HCG does not reflect the same prognosis. Subgroups of germ cell tumors with syncytial trophoblasts, so these are your mixed germ cell tumors, can secrete both beta-HCG and have a slightly poorer prognosis compared to pure germ cell tumors. alpha-fetoprotein elevation in serum and CSF tend to correlate with each other, whereas beta-HCG elevation in serum and CSF does not is not always associated with the identically elevated serum levels. Next. So I think we can skip this. We've gone through this already. Yeah. So take-home message, hydrocephalus is an urgent neurosurgical problem. Needs to be dealt with urgently. If you see patients with mentioned with Perinaut Syndrome, in this case, think of brainstem lesion. Yeah. So I would like to open the floor at this stage for any questions and answers.
Ramesh, I think there's a question for you in the chat.
Oh, okay, just have it.
The question is, Prof. Ramesh, is the colostomy permanent or will be reversed after we did the third ventriculostomy?
Okay, so the third ventriculostomy is a permanent procedure. It provides an alternative channel for CSF drainage. So it's a very good indication when the aqueduct is narrowed. So in cases of aqueduct stenosis, or you have tumors either in the posterior fossa or in the pineal region like this, compressing the aqueduct. So we perform a third ventriculostomy. The procedure is permanent. It can block off with time, so we need to monitor these patients and keep a close eye on them. If it does close off, then we'll need to repeat the procedure again.
Okay, Prof. Ramesh, so far that's all the questions. Yeah, so
okay.
I would like to thank all the panelists for spending your time in today's presentation. I hope this case has opened up your eyes regarding the neurosurgical tumors, which is quite rare to see, even so the Perinaut syndrome. So thank you again for everyone.
Okay, bye.
Bye, thank you all very much. Thank you for the panelists for all the hard work. Brilliant case, thank you.